Ya wes.
Jul,
Wis. Jul wan Jul.
Dari Filipina, dari Uzbekistan.
Uzbekistan.
Oke, piye? Aman.
Oke, dulu. A very good morning to every brilliant mind joining us from your respective locations across time zones and continents. Whether you are tuning in from a bustling city or a quiet corner of your home through the digital window of today's seminar, it is an absolute privilege and a heartfelt joy to stand before you, virtually yet vividly, as your master of ceremonies for today's momentous occasion, Urgency 2026. International Hybrid Seminar and Student e-Poster Competition with a profound focus on infectious and metabolic diseases in global health. My name is Igede Saduananswara, and I'll be your guide through this morning's intellectual journey, a journey that weaves together science, collaborations, and the unwavering spirit of global solidarity. Today is not merely a seminar, it is a convergence of curious minds, seasoned experts, and emerging young researchers. It is a platform where boundaries dissolve between disciplines, between nations, and between generations. We are here to dissect, discuss, and co-create solutions for two of the most pressing health adversaries of our time, infectious diseases and metabolic disorders. So, before we dive into today's ocean of knowledge, let's take a collective breath of enthusiasm. Welcome, everyone. Welcome to Urgency 2026. Now, allow me to walk you through the flow of our session, the roadmap of today's intellectual voyage. We will begin with a registration from 8 to 8:30. But since you are already here with us, consider yourself perfectly on time. Then, we are here, the opening by your Master of Ceremonies. After that, we will rise in the spirit for Indonesia Raya and the Mas Bela Negara. The opening speech by the Dean of the Faculty of Medicine, UPN Veteran Jawa Timur, will grace us after the singing of Indonesia Raya and the Mas Bela Negara. After that, invited speaker from Indonesia, Dr. Muhammad Soifi, SPOT. The first keynote speaker from Indonesia, Professor Dr. Haja Rika Yuli Wulandari, our esteemed Dean. The second keynote speaker from Australia, Dr. Anthony Paulo Sunjaya. The third keynote speaker from the Philippines, Ms. Riza Bautista Lumagui. The fourth keynote speaker from the United Kingdom, Mr. Dono Widiatmoko. Finally, we'll disperse into the parallel presentations where the real magic of student research and e-poster unfolds. So, fasten your intellectual seatbelts. We have a rich, accelerating schedule ahead. Ladies and gentlemen, to instill our spirit of nationalism, we will now proceed with the singing of the Indonesian national anthem, Indonesia Raya, followed by the Mas Bela Negara. We kindly invite you to sit upright and observe a moment of reverence. Sorry for the inconvenience. Please wait kindly. Ladies and gentlemen, it is my distinct honor to welcome to the virtual podium a visionary leader and advocate for transformative medical education and the esteemed Dean of the Faculty of Medicine, UPN Veteran Jawa Timur. Please join me in welcoming Professor Dr. Haja Rika Yuli Wulandari, Master of Health Science, MMB, PhD, SP-KKLP, Subspecialist FOMC. Professor, the floor is yours.
Thank you, Gede. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, peace and happiness for all of us. Our invited speaker, Dr. Muhammad Soifi, SPOT Consultant, Head of Indonesian Medical Association, Surabaya branch. Our distinguished keynote speakers, Mr. Anthony Paulus Sunjaya, MD, MSc, PhD from University of New South Wales, Ms. Riza B. Lumagui, RN, MAN, MBA, Dean of Faculty of Nursing, Far Eastern College, Silang, Philippines, Mr. Dono Widiatmoko, SKM, MSc from University of Derby, UK, Dr. Chen Hin Sui, Vice Superintendent, National Taiwan University Hospital. Our speaker in the afternoon session, Dr. Chang Che Hao and Dr. Wen Cheng Yu from National Taiwan University Hospital, and also speaker from our Faculty of Medicine, UPN Veteran Jawa Timur, Dr. Prasetyaning Estu Pratiwi, MMP, SPPD Financing. Also the moderators, respected colleges, Master of Ceremony, researchers, healthcare professionals, students, and also all participants who joining us both on-site and virtually from various countries. It is really my great honor and on behalf of the Faculty of Medicine, UPN Veteran Jawa Timur, to warmly welcome all of you to our third urgency, International Hybrid Seminar and Student e-Poster Competition 2026. This year's theme is about infectious and metabolic diseases in global health. It is not only academically relevant, but this topic is really strategically urgent for our global society. Ladies and gentlemen, around the world, healthcare systems are facing a dual burden. On one side, infectious diseases continue to evolve through emerging pathogens. The rise of antimicrobial resistance, climate-related health threats, and also disaster-associated outbreaks. On the other hand, metabolic diseases, including obesity, diabetes, cardiovascular disorders, and also metabolic syndromes, are silently becoming one of the greatest public health challenges today. The convergence of these two health threats demands something beyond conventional medicine. We need interdisciplinary science, translational research, digital innovation, policy leadership, as well as global partnership. As the Faculty of Medicine, UPN Veteran Jawa Timur, already established under the mandate of the Minister of Education in 2023, then our institution carries a distinctive mission to develop future physicians with excellence in disaster medicine, emergency preparedness, and global health leadership. This mission reflects our institutional vision to become an excellent faculty in disaster medicine with the character of national resilience. Today, as a part of our third anniversary, we are deeply honored to welcome distinguished experts and academic partners from Indonesia, Australia, the Philippines, United Kingdom, Taiwan, and also the student from Uzbekistan. It is a privilege to bring together such a diverse group of experts to discuss, share, and advance knowledge across borders. Your combined expert is invaluable for addressing the complex global challenges that we face today. We look forward to a productive and enriching exchange of ideas throughout this event. To all students who participate in the e-poster competition, I would like to emphasize that research is not only about publishing evidence. Research is about creating impact. So the ideas you present today may become tomorrow's innovation, policies, technologies, or life-saving interventions. Our Faculty of Medicine UPN Veteran Jawa Timur continues its journey toward internationalization agenda and global impact commitment. We believe that collaboration among universities, healthcare institutions, industry, policymakers will be the key to achieving sustainable health for all. Before I conclude, please allow me to express my sincere appreciation to all organizing committees, faculty members, students, our collaborators, and international partners whose dedication has made this prestigious event possible. Also, from ED Surabaya branch that also has supported this event and attended by the head of the Indonesian Medical Association Surabaya branch. Last but not least, I would share this beautiful quotation. In a world full of uncertainty, science gives direction. In a world full of threats, collaboration creates resilience. And in a world that needs hope, health is a vital pillar. With the blessing of Almighty God, I officially declare the International Hybrid Seminar and Student e-Poster Competition, Third Urgency 2026, officially open. Thank you for your participation, support, and attendance. Wassalamualaikum warahmatullahi wabarakatuh.
A resounding thank you to Professor Rika for her inspiring words and unwavering commitment to advancing global health collaboration. Now we transition into the first core session, a sequence of insightful presentations from distinguished national and international thought leaders. Our first speaker brings a wealth of clinical expertise and organizational leadership from the front lines of Indonesian medicine. Hailing from the Ikatan Dokter Indonesia Surabaya, he is a specialist in orthopedics and traumatology, whose perspective bridges surgical precision with public health realities. Please welcome warmly Dr. Muhammad Syafi, SPOT.
Terima kasih, thank you. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillah wa syukurillah wa ala ni'matillah wa ala di'alama ba'du. Pertama-tama kita ucapkan terima kasih pada yang terhormat Dekan Fakultas Kedokteran UPN Jawa Timur dan juga seluruh pembicara, all speakers dari Indonesia maupun dari luar negeri. Mohon maaf saya akan menyampaikan dalam bahasa. Kemudian juga kepada seluruh panitia. Dan kami juga dari Ikatan Dokter Indonesia di cabang Surabaya mengucapkan selamat kepada HKUPN atas Disnatalis yang ketiga dan bisa menyelenggarakan acara yang luar biasa. Dan kita dari ID diberikan kesempatan oleh Prof. Rika untuk bisa menyampaikan ya terkait dengan hal-hal mungkin yang perlu kita ketahui sebagai mahasiswa kedokteran maupun juga sebagai organisasi profesi. Jadi ID sebagai organisasi profesi. Mohon izin saya akan menyampaikan, slide saya sudah tampak ya. Oke, saya akan menyampaikan terkait dengan tantangan dan peran organisasi profesi Ikatan Dokter Indonesia di era litigius. Saya punya waktu kurang lebih sekitar 15 menit dan kita akan mulai dengan apa itu future medical doctor. Jadi membayangkan karena para mahasiswa kedokteran, ya khususnya di FK UPN, kita sekarang masih dalam masa tahapan belajar, begitu. Membayangkan apa yang sebenarnya tentang medical doctor di masa yang akan datang. Mungkin seorang dokter yang kita bayangkan adalah dokter yang menguasai pada aspek precision medicine, yang menguasai pada aspek genomik. Dia seorang periset yang hebat seperti Prof. Vikain. Kemudian seorang klinisi yang juga hebat. Terus ada tambahan hal-hal yang baru, ya, bahwa dia seorang dokter di masa yang akan datang juga harus seorang medico entrepreneurship yang menguasai AI atau artificial intelligence dan juga menguasai pada aspek data science. Nah, kita sekarang dihadapkan pada realitanya. Yang tadi adalah gambaran idealisme seorang dokter di masa yang akan datang, dan yang saat ini faktanya atau realitanya bisa kita lihat ya di media-media. Bahwa ada dugaan malpraktek, fakta dokter terlibat kasus selebgram tewas usai sedot lemak. Terus ada juga berita di media bahwa Majelis Disiplin Profesi ungkap update dugaan malpraktek dokter senior di RSCM dan lain sebagainya. Ini yang kita hadapi, fakta-fakta yang memang harus kita jalani. Sekarang kita bicara tentang apa tantangannya, ya khususnya bagi para mahasiswa kedokteran ataupun dokter-dokter muda yang akan menapaki jalan untuk menjadi dokter masa depan Indonesia. Yang pertama pada aspek akademik dan ilmu pengetahuan, di mana beban kurikulumnya makin lama akan dirasakan semakin berat. Dan yang terjadi juga evolusi ilmu pengetahuan dan teknologi kedokteran makin berkembang dan semakin luas. Dan ini harus kita kuasai. Kemudian yang ketiga adalah integrasi pada aspek teknologi. Apa itu? Artificial intelligence, precision medicine, maupun juga genomics. Tantangan yang kedua apa? Tantangan yang kedua bagi mahasiswa kedokteran dan juga dokter Indonesia di masa depan adalah terkait dengan etika dan profesionalisme. Di mana saat ini pasien sangat kritis, ya, sangat kritis. Mereka punya literasi sendiri ya dalam tanda kutip. Mereka punya analisis sendiri dan mereka bukan lagi pasien-pasien atau kumpulan masyarakat yang apa katanya dokter mereka bisa mengikuti, tapi mereka adalah orang-orang yang kritis. Kemudian era yang saat ini kita hadapi dan ke depan yang disebut sebagai era masyarakat litigasi. Nanti akan saya jelaskan apa itu. Kemudian yang kedua adalah dilema pada aspek bioetika. Tantangan berikutnya apa? Tantangan berikut yang ketiga adalah pada aspek sosial dan kesehatan global. Di mana kita tahu pada situasi Indonesia terjadi maldistribusi atau distribusi tenaga dokter yang tidak merata. Lebih banyak terkonsentrasi di kota-kota besar maupun di Pulau Jawa, padahal pulau-pulau di Indonesia, kota-kota yang lain di Indonesia masih sangat banyak dan sangat luas. Kemudian yang kedua adalah masalah aspek kesehatan global dan penyakit baru. Ini mungkin yang harus kita hadapi, seperti kurang lebih beberapa tahun yang lalu, kita menghadapi satu pandemi COVID-19. Dan ternyata pada aspek ketahanan dan sistem pelayanan kesehatan, hampir semuanya di seluruh dunia tidak mampu menghadapi itu. Sehingga kita harus juga bersiap untuk menghadapi pada aspek kesehatan global dan juga penyakit baru. Yang ketiga adalah keadilan kesehatan, di mana keadilan kesehatan ini harus dirasakan oleh seluruh lapisan masyarakat. Kemudian berikutnya apa? Tantangan yang keempat adalah kompetensi pada aspek non-medis. Bahwa mahasiswa kedokteran atau dokter-dokter muda di Indonesia di masa yang akan datang harus menguasai soft skill. Apa itu soft skill? Terutama pada aspek kepemimpinan, pada aspek leadership. Dan ini harus terus bisa diasah pada saat kita berada pada tataran mahasiswa. Kemudian yang kedua adalah entrepreneurship medis. Ini akan menjadi sebuah tantangan besar di masa kini dan masa yang akan datang, bahwa mahasiswa kedokteran tidak hanya menguasai pada aspek yang terkait dengan klinis atau akademik kedokteran saja, tapi juga menguasai pada aspek entrepreneurship medis, pada aspek kompetensi non-medis yang juga mereka harus punya. Kemudian yang ketiga adalah health economics dan policy. Bahwa inovasi layanan kesehatan, startup health teknologi, dan juga manajemen rumah sakit akan menjadi sebuah area baru di masa yang akan datang yang pasti akan sangat menantang. Tantangan berikutnya apa? Pada aspek kualitas personal. Jadi kita tahu bahwa mahasiswa-mahasiswa kedokteran saat ini diisi oleh generasi yang mereka sangat melek teknologi. Mereka punya kecerdasan yang luar biasa. Tapi menjadi tantangan berikutnya adalah kualitas personalnya. pada aspek kesehatan mental dan juga identitas profesionalnya ke depan. Nah, secara kesimpulan, apa saja tantangan masa depan, bisa pada aspek akademik dan ilmu pengetahuan, beban kurikulumnya sangat berat, ilmunya sangat cepat berkembang, sehingga dokter harus menyiapkan diri untuk lifelong learning, adaptif terhadap hal-hal yang baru, terutama pada aspek teknologi yang terus berkembang. Pada aspek etika dan profesionalisme, pasien saat ini sudah sangat kritis, dan eranya masyarakat adalah litigious society. Sehingga dokter dituntut untuk bisa tetap humanis, menjaga etik profesi, dan juga peka secara hukum. Pada aspek sosial kesehatan, ada ketidakmerataan distribusi yang tadi saya jelaskan, maka dokter harus bisa siap ditempatkan di mana saja, berpikir secara global, tanggap isu kesehatan masyarakat, dan mungkin juga bersiap. Ini yang saat ini mungkin dimulai oleh Prof. Rika, bahwa dokter Indonesia masa depan bisa jadi tidak hanya bekerja di Indonesia, tapi secara global harus mampu menjadi dokter pada masyarakat internasional, mampu berkompetisi, mampu bersaing. Ini mungkin tantangan dari dokter Indonesia di masa yang akan datang. Kemudian pada aspek kompetensi non-medis, banyak generasi ini lemah pada aspek soft skill, maka ini yang harus dikuatkan. Karena dokter masa depan harus mampu menjadi seorang pemimpin, menjadi komunikator yang handal, menjadi inovator, bahkan ke depan bisa jadi ya orang-orang yang punya kualitas bagus ya, seperti Prof. Rika misalnya adalah menjadi health policy maker. Ini yang kita harapkan yang bisa disiapkan juga oleh para mahasiswa kedokteran untuk menyiapkan diri menghadapi tantangan-tantangan seperti itu. Kemudian pada aspek pribadi dan psikososial, stres akademik, burnout, ya, ini yang perlu dikuatkan untuk menjaga pada aspek kesehatan mental dan punya identitas profesional yang kuat. Ini tantangan yang berubah, ini tadi yang saya sampaikan, bahwa saat ini kita dihadapkan pada aspek liberalisasi di bidang kedokteran dan kesehatan. Kemudian yang kedua, litigious society. Nanti akan dijelaskan apa itu litigious society. Yang kemudian yang ketiga adalah teknologi dan digitalisasi medik. Tantangan yang berubah ini akan terkait dengan aspek etik yang pertama. Maka akan banyak, bisa kita prediksikan, pelanggaran-pelanggaran etik yang terjadi. Yang kedua, bahwa ternyata profesi dokter ini juga terkait pada aspek hukum. Masyarakat makin kritis, kita berada pada situasi litigious society pada masyarakat, di mana masyarakat itu mudah menuntut dan memviralkan, maka akan makin banyak terjadi sengketa medis. Kemudian relasi dokter dan pasien akan menjadi semakin transaksional. Apa itu litigious society? Nah, ini sekarang kita masuk pada litigious society, bahwa kita dihadapkan pada masyarakat yang situasinya sangat suka berperkara. Kecenderungan tinggi untuk menyelesaikan masalah atau sengketa melalui jalur hukum dan tuntutan pengadilan. Cirinya dua, masyarakat mudah menuntut dan mudah memviralkan. Ini adalah sebuah berita di Amerika pun mereka ya di negara maju mengalami hal yang sama. Ternyata kultur litigasi ini bisa menyebabkan burnout pada dokter-dokter yang di Amerika. Maka kalau kita memandang bahwa Amerika itu 10 atau 20 tahun ke depan dibandingkan era yang saat ini kita hadapi di Indonesia, maka tentu kita akan berjalan ke arah yang sama. Dan saat ini sudah kita hadapi. Nah, ini tata nilai wajib bagi dokter yang mungkin pada saat teman-teman adik-adik mahasiswa kedokteran saat ini belajar mulai menyiapkan diri. Apa itu? Yang pertama adalah etika. Karena pelanggaran etika, maka akan ada proses secara etik dari organisasi profesi. Yang kedua, memahami, menguatkan pada aspek disiplin profesi. Kenapa? Karena pelanggaran pada aspek disiplin profesi akan bisa terkait pada proses disiplin yang saat ini dilakukan oleh Majelis Disiplin Profesi. Yang ketiga pada aspek hukum, di mana dokter atau tenaga kesehatan yang apabila terjadi sengketa hukum, pelanggaran hukum, maka prosesnya adalah proses hukum, bisa ke polisi, kejaksaan, maupun pengadilan. Nah, ini standar etik. Di organisasi profesi, kita punya yang disebut sebagai Kode Etik Kedokteran Indonesia, dan juga Sumpah Dokter. Ada banyak pasal yang harus kita pahami, yang harus kita bawa, yang insight sebagai seorang dokter Indonesia untuk memahami ini. Bila terjadi pelanggaran, maka kita akan mendapatkan sanksi secara etik dari organisasi profesi. Yang kedua adalah memahami standar disiplin. Jadi ada Permenkes nomor 3 tahun 2025 sebagai turunan dari Undang-Undang 17 tahun 2023. Nah, yang harus kita pahami pada aspek standar disiplin itu ada 3 batu ujinya. Standar profesi, standar pelayanan, dan juga standar prosedur operasional. Sebenarnya bisa kita jelaskan secara rinci, cuma nanti mungkin ini juga terkait dengan waktu. Jadi gambaran secara garis besarnya pada aspek standar disiplin, 3 standar atau batu ujinya. Standar profesi, pelayanan, juga prosedur operasional. Ini adalah jenis pelanggaran disiplinnya. Kemudian sanksinya apa saja, karena terkait nanti apabila ada pelanggaran pada aspek disiplin profesi, maka bisa dilanjutkan pada aspek hukum. Nah, ini juga standar hukum. Ya, standar hukum ada KUHP dan ada KUHP, dan banyak pasal di sana terkait dengan jenis tindak pidana yang kemudian bisa dilanjutkan pada aspek hukum. Nah, ini harus juga kita pahami sebagai mahasiswa kedokteran yang akan beroperasi sebagai dokter di masa yang akan datang. Apa peran krusial organisasi profesi? Nah, ini tujuan dari ID, meningkatkan derajat kesehatan, mengembangkan ilmu pengetahuan dan teknologi kedokteran, membina dan mengembangkan kemampuan profesi dokter, dan juga melindungi kepentingan profesi dokter. Tidak hanya melindungi kepentingan profesi dokter, tapi juga melindungi kepentingan masyarakat. Ini adalah fungsi ID, maka ke depan ini kita sampaikan kepada teman-teman dokter, kepada teman-teman mahasiswa yang nanti akan lulus menjadi seorang dokter, jangan pernah meninggalkan organisasi profesi dokter di era kini dan ke depan. Memang undang-undangnya, regulasinya memungkinkan untuk tidak menjadi anggota profesi, tidak menjadi anggota organisasi profesi. Tapi tantangan ke depan, bila berjalan sendirian, tanpa dilindungi, tanpa dibina, tanpa dilingkupi dengan society yang jelas yang disebut organisasi profesi, dalam hal ini kalau kita di Indonesia adalah ID, maka tantangannya ke depan akan semakin berat. Terutama bila terjadi pada aspek pelanggaran etika, pelanggaran disiplin profesi, maupun juga pelanggaran hukum. Ini adalah organisasi profesi kita kembangkan di Surabaya. Setidaknya ada 5. Kita menguatkan, membina pada etik dan kesejawatan, pada aspek profesionalisme dan pendidikan berkelanjutan dari seorang dokter, pelindungan hukum dan kesejahteraan, transformasi sistem kesehatan, dan juga advokasi kebijakan masyarakat. Nah, ini membangun visi masa depan kita di Surabaya, mengembangkan apa yang disebut sebagai ID rumah kita, yang kita harapkan punya kemanfaatan besar pada aspek kesejahteraan dan juga aspek kemanfaatan kepada masyarakat. Ini adalah kita ID Rumah Jawat, jadi nanti kita mengundang silakan ya mahasiswa-mahasiswa kedokteran di FK UPN untuk bisa hadir, bisa berkembang, ya, bisa mengembangkan diri, bisa berinteraksi secara lebih luas dengan Ikatan Dokter Cabang Surabaya. Kita sangat terbuka, ya. Kita punya acara-acara, kita punya aspek pelindungan dan pembinaan hukum, kita punya corporate lawyer secara khusus begitu. Yang ini bagi anggota ID Surabaya. Kemudian bagi mahasiswa kedokteran, bagi dokter-dokter muda, kita punya acara-acara khusus, ya. Ada Inspiring Leadership Series, ya. Sekarang sudah seri yang ketiga, menjelang keempat. Dan kita akan juga mengundang Dekan FK UPN, Prof. Rika, untuk juga bicara, menjadi inspirasi bagi dokter-dokter muda, mahasiswa kedokteran di acara ini, ya. Kita setiap Sabtu setiap bulan yang kita sebut sebagai Inspiring Leadership Series. Dan kita juga kita punya acara ilmiah mingguan yang kita sebut New Dolan. Ini adalah ide rumah manfaat. Kita mengembangkan proyek Surabaya Sehat untuk Semua. Kita punya MOU dengan pemerintah kota yang kita harapkan bahwa Ikatan Dokter Indonesia sebagai organisasi profesi dokter tidak hanya punya kemanfaatan yang kuat pada aspek akademik, keilmiahan bagi sejawat dokter, tapi juga menjadi manfaat yang besar bagi masyarakat, ya, bagi masyarakat khususnya di Kota Surabaya. Maka kita mengembangkan yang kita sebut sebagai proyek Sehat untuk Semua di Kota Surabaya, beserta bersama dengan Wali Kota Surabaya. Nah, ini slide yang terakhir terkait dengan seperti apa gambaran future medical doctor, true future medical doctor di masa yang akan datang. Bahwa gambaran seorang dokter masa depan, dia menguasai pada aspek precision medicine, dia menguasai tentang genomik, dia peneliti yang hebat, dia seorang klinisi yang juga sangat mumpuni, dia memahami tentang medical entrepreneurship, dia juga menguasai pada AI dan juga data science. Tapi apakah itu cukup, pertanyaannya? Ternyata dokter masa kini dan masa yang akan datang dengan fakta-fakta yang ada, dengan tantangan di masa depan yang bisa kita baca, kita prediksikan dari sekarang, ternyata itu tidak cukup. Bahwa seorang dokter kini dan ke depan di Indonesia khususnya harus memahami pada aspek etik, memahami, menjalankan pada aspek disiplin, dan juga memahami dan menjalankan pada aspek hukum. Untuk apa? Untuk mempertahankan, menjaga bahwa dokter adalah profesi officium nobile, atau profesi yang sangat terhormat dan mulia. Dan pada akhirnya dokter yang bukan hanya profesi, tapi juga dokter yang bisa menjadi pelayan kemanusiaan. Itu mungkin yang saya bisa sampaikan pada Disnatalis FK UPN Jawa Timur pada hari ini. Saya ucapkan terima kasih kepada Ibu Dekan, Prof. Rika atas kesempatannya, kepada seluruh pembicara dan juga panitia yang memberikan kesempatan pada saya, pada kita dari di Surabaya untuk bisa sharing terkait dengan organisasi profesi Ikatan Dokter Indonesia. Saya ucapkan selamat sekali lagi, saya ucapkan terima kasih, mohon maaf bila kekurangan. Billahi taufik wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh. Terima kasih.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you very much, Dr. Sharifi. Navigating the evolution of science and integrating new technology is certainly a challenge. But as we just learned, the future of AI, precision medicine, genomics, and many more holds an incredible promise. Ladies and gentlemen, our next keynote speaker is a figure who many of you already hold in high esteem. It is a privilege to introduce someone who leads not only by title, but by example, dedication, and scholarly excellence. She is the Dean of the Faculty of Medicine at UPN Veteran Jawa Timur, a distinguished researcher in the fields of pharmacogenomics and family medicine, and a true driving force behind this very seminar. Her expertise is both deep and broad, and today she will kindly share with us Indonesia's strategic approach to confronting the dual burden of infectious and metabolic diseases. Ladies and gentlemen, please join me in giving a warm welcome and respectful welcome to Professor Dr. Haja Rika Yuli Wulandari, Master of Health Science, MMB, PhD, SPKKLP, Subspecialist FOMC. Professor, the floor is yours.
Thank you, Gede, for your introduction. And also thank you, Dr. Salvi. You already introduced our student about Indonesian Medical Association and what the student have to do to be the doctor. So I would like to share my slide. Yeah. I wonder whether the slide is already on screen.
Yes, Prof.
Thank you. So good morning, everyone. My talk today would be about pharmacogenomics, a hope for tuberculosis eradication in the precision medicine era. As all of us might know that every cell in our body contains DNA. This is a complex code that serves as the master instruction manual for building and maintaining our body. Our genetic blueprint dictates our physical characteristic, our skin color, eye color, hair, height, body type. Even it is also dictate our disease predisposition, whether we are susceptible or resistant to certain diseases and health conditions throughout our life. So our genetic code is our body's instruction manual. So how if our genetic code also affect the drug metabolism in the body? That is what we call pharmacogenomic. So we can define pharmacogenomic studies as how genetic variation affect individual responses to medications from efficacy to safety. Our genes control how our body absorb, distribute, metabolize, and eliminate medications through complex biochemical pathways in the body. The question is, why the genetic differences matters? That is because the variation in our genetic explain why the same drug with the same dose works very well for one person, but can cause side effect or fails in another person. And that is the urgent needs of implementation of precision medicine, as what Dr. Sophie just said before. The precision medicine is an innovative approach to disease treatment and prevention that tailors strategies based on individual variability in genes, environment, and lifestyle. Based on the genetic variation, we can classify the phenotypes of drug metabolism into several groups. The first group is rapid metabolizer. In this group, drugs process very quickly in the body, so the patient may experience treatment failure even at standard dose. The second group is normal metabolizer or intermediate metabolizer. In this group, the drug undergoes standard processing speed, so the patient responds well to typical medication doses. The third group is slow acylator or slow metabolizer. In this group, the drug undergoes moderately slow processing, so the drug may accumulate. There may be accumulation of excessive drug levels at normal dose. And the other group is ultra-slow metabolizer. The drug undergoes very slow processing that lead to the high risk of severe adverse effect even with the standard dosing. So how is the role of pharmacogenomics? Before we go further, I would like to a little bit discuss about the tuberculosis situation in the world. As we know that tuberculosis remains a formidable global public health concern. According to WHO Global TB Report in 2025, based on the situation in 2024, the incident case of TB worldwide is about 10.7 million people with TB cases, and 1.23 million people die because of the disease. That's why we need effective and well-tolerated treatment strategies. See in this map that some countries highlighted with darker green color. So in total, there are about 30 high TB burden countries that contribute to the global TB cases in the world in 2024. And you can see here, the top 3 countries are India, Indonesia, and Philippines. All of these 3 countries contribute 41.8% of the worldwide TB cases, with the highest is in India, 25%, Indonesia 10%, and Philippines 6.8%. However, the problem is the treatment of tuberculosis is still challenges. So far, there is no single drug that effective to combat TB. The first line TB treatment is combination of multi-drug, rifampicin, isoniazid, pyrazinamide, ethambutol, and also streptomycin. These drugs combination often cause adverse reaction, and the common adverse reactions are hepatotoxicity. This is a liver damage that is a significant concern, then often leading to drug discontinuation. The other common adverse reactions are gastrointestinal disorders such as nausea, vomiting, and abdominal pain, and then allergic reaction ranging from skin rashes to more severe systemic response, as well as neurological disorders such as peripheral neuropathy and other neurological symptoms. And among all those multi-drug treatment for TB, the isoniazid is one of the cornerstone of anti-TB therapy, but it is a kind of double-edged sword because in one side, isoniazid acid is main drug. However, in the other side, it is also the primary culprit behind drug-induced liver injury or ATDLI during treatment. The ATDLI or hepatotoxicity is the most common adverse drug reaction that leading to drug discontinuation in 5 to 33% of TB patients. Therefore, we need closer monitoring and better management strategies. This figure shows the pathways of isoniazid metabolism. The main pathways of isoniazid metabolism is through N-acetyltransferase 2 through acetylation that convert isoniazid into acetyl isoniazid. However, the NAT2 acetylation capacity depend on the NAT2 genetic variation, whether the patient will go through this main pathway or go through the alternative pathway. And based on the NAT2 genotype, we can classify the acetylator phenotype at least into 3 different groups. The first group is fast acetylator. In this case, there is a rapid isoniazid clearance in the body of the patient that led to a risk of subtherapeutic drug level and potential treatment failure if the dose is not adjusted. The second group is intermediate acetylators. In this group, the metabolism rate is moderate, so the patient can maintain a more balanced profile of efficacy and get lower toxicity risk. And the third group is slow acetylators. In this group, there is a slower isoniazid clearance that led to higher plasma levels and significantly increased the risk of drug-induced hepatotoxicity. According to NAT2 genotype, fast acetylator phenotype is coded by homozygous of NAT2-4, NAT2-11A, 12A, 12B, 12C, and 13. And slow acetylators is either homozygote or heterozygote of NAT2-5, NAT2-6, or NAT2-7 allele. And the intermediate acetylator is coded by heterozygous fast and slow acetylator NAT2 genotype. How is the situation in the world? This figure shows the map of NAT2 phenotype distribution in many countries around the world. And we can see here the dark yellow represent the slow acetylator and the light yellow represent the fast acetylator. We can see that in the countries, especially in the European continents and also some part of African continent, the majority of population there, the fast acetylator is more frequent than slow acetylator. Whereas in the ASEAN population, the situation is a bit opposite. And especially we can see here in Indonesia, this is based on my study, the proportion of NAT2 slow acetylator is around 35% that I will inform you later in the next slide. So based on this figure, we can see that NAT2 shows significant genetic diversity across population. The high proportion of slow acetylator indicate that there is an increased risk of adverse drug reaction globally. This slide shows the finding on NAT2 study in Indonesia that mainly based on my study and my team study. As information that NAT2 gene is located in the short arm of chromosome 8. It contains 870 base pair intronous protein coding region. In my study published in 2008, within the coding region, I found 6 SNPs in the NAT2 coding region that determine the NAT2 phenotype in Indonesia, especially at the time in Javanese population. We can see here that I have conducted study in Javanese population, Sundanese population, and Bugis population that was published in 2008, 2016, and 2017. And amazingly, NAT2 slow phenotype were found in more than 35% of population in these 3 populations. It means that our population are more prone to develop adverse drug reaction. The other study on 2016 among Indonesian TB patients Surprisingly, we found that 64% of our TB patients with antituberculosis drug-induced hepatotoxicity also carry slow NATU genotype and have NATU slow phenotype. Another study using meta-analysis approach that incorporate 139 studies throughout the world. This is the project under the CFAM collaboration between genetic researcher around the world, especially Southeast Asian countries. We found that slow oscillator has 2.8 times higher risk to develop antituberculosis drug-induced hepatotoxicity, whereas ultra-slow oscillator that carries NATU6A and NATU7B genotype even has 3.6 times higher risk to develop antituberculosis drug-induced hepatotoxicity compared to fast oscillator. This finding were confirmed by our team study published in 2019 using 180 daily patients with clinically severity group compared to 210 non-80 daily tuberculosis controlled group. In this study, we found that there was strong association between slow oscillator phenotype with ATDH with the p-value 10 to the minus 6 with odds ratio over than 3. And again, we confirm that the patient that carry NATU6A and NATU7B that classified as ultra-slow oscillator is more dominant among ATDH patients. The other study published in 2022, we confirmed that slow oscillators show lower clearance of isoniazid. We can see in this figure, in this graph, that slow oscillator has significantly lower isoniazid clearance compared to intermediate and rapid. This study using one compartment model. So as slow oscillators have significantly lower isoniazid clearance, leading to higher exposure of isoniazid and has toxicity risk. So as the summary, NATU genetic variation is a key point to better TB treatment outcomes. NATU genetic variations profoundly impact isoniazid metabolism and the crucial risk of development of toxicity in TB treatment. According to Indonesian data, especially by Yuli Wulandari's research group, confirmed that significant clinical relevance of these genetic factors, specifically within Indonesian population. Therefore, we need to tailor isoniazid dosing. We need to apply TB treatment guided by NATU genotype to give a promise to deliver safer and significantly more effective TB treatment. The pharmacogenomic in tuberculosis treatment is best described as a whole that is gradually shifting from research to clinical reality rather than just hype, though it faces significant implementation hurdles. So I would like to invite all of you for call to action toward precision medicine in tuberculosis by first, we need to integrate genotyping data. We implement NATU genotyping into routine TB treatment protocols worldwide for more precise care. We need to invest pharmacogenomic testing, especially rapid point of care assay, especially in the endemic regions, and also building capacity and expertise. Also, we need to empower our clinicians to provide healthcare professionals with the necessary tools to customize therapy to boost cure rates and patient safety. Thank you for listening. And last quotation from me, from genomics to global goals, precision medicine accelerates TB elimination.
Profound gratitude, Professor. Your visionary framing sets the stage for truly cross-cutting dialogues. Let us now traverse the digital expanse to the land down under, Australia, Our second keynote speaker is a physician scientist who works at the intersection of primary care, chronic disease, and health system innovations, has garnered international acclaim. He is affiliated with the University of New South Wales, one of the world's leading research universities. It is a privilege to welcome Dr. Antony Paulo Sunjaya, medical doctor, MSc, PhD. Dr. Sunjaya, the virtual floor is yours.
Thank you. Thanks for that kind introduction and the invite to speak here today. And my greatest appreciation as well to the organizers for running today's meeting. I would like everyone now to take a bit of a step back. I think Prof. Wulandari has been has been wonderful in putting the context about precision medicine and how we can improve outcomes, especially for patients on the ground. But today I would talk about something bigger picture. That is, how do we think beyond healthcare systems, which is still the same goal, which is achieving good health for all. I'll share my screen just in a second. Can you see my screen?
Yes, doctor.
Okay. I'll just move on. For those of you who's not aware, I'll just give a bit of introduction as well from where I'm at and my background. So I'm based at UNSW Sydney. Oops, I think it's progressing faster than it should be. I'm based at UNSW Sydney. We're a world-leading university with the goal of progress for all. And this really involves meaningful engagement and collaboration with global partners around the world to improve and transform lives through excellence in research and outstanding education, part of which is what I do here today. We're a top 20 university around the world, and for public health, where I'm based at, we're ranked 17 in the world. A bit about myself, I think as mentioned, so I'm a primary care doc by background with postgraduate training in internal medicine, though I ended up moving towards the digital health space through my PhD and have done a number of studies across a variety of sectors. Clinically, I would say my focus areas have always been cardiovascular disease, respiratory disease, diabetes, and the multimorbidities that come with them, as we're all aware. And I do variety of approaches in answering these questions, be it through health system interventions, clinical trials, health policy changes, and work around the world. Still, as well, a number of collaborations in Indonesia, but also more broadly in the Asia-Pacific region, in Europe, and in the US. And my philosophy has always been, in my group, how we think at the individual level and also at the same time look towards the systems, because they need to work together to improve outcomes. And that's where I think Professor Yuli Wulandari's talk about focusing on that precision medicine aspect is a good segue, hopefully, to my talk today. And these are my 3 areas of focus, as mentioned earlier. So I'll go back to the main point of my discussion today, which is how do we, including those who are working on the front lines, think more broadly about healthcare systems to achieve good health for all, and also why I think more importantly we should do that. Because I'm not here to tell you what to do. I do want you to think about this for your own. I think everyone's aware that we are living longer. There's no question about it, be it in Indonesia, be it in Japan, be it in Australia. The world has done tremendously to improve our life expectancy. And if we look at the projected scenario in the figure shared here, we can see that by 2050, the number of people aged 65 and above will double the number of children aged under 5. And we're already at that tipping point in 2018, where actually the number of people 65 years and older outnumber the population of children. And this is important because this is a trend that will continue, as we can see here. due to many reasons. A lot of it are societal. It's certainly a result of improved healthcare access, improved quality of healthcare, improved healthcare technologies, be it today, for example, AI and robotics or precision medicine, but a lot of it comes because of changes in the environment and societal expectations. But a lot of these individuals would live longer with chronic disease. I think in 2019 alone, this is the most recent data from WHO, over 40 million people die of chronic diseases. And this involves cancer, diabetes, CVD, but also respiratory related conditions, of which is of greatest interest to me. And if we look at this again more closely, a lot of these deaths are in lower middle income countries, where we would have expected that communicable diseases are the main burden. So that is something that Indonesia, where you're at, needs certainly to keep in mind and invest more in, which I think we've seen recently and it's great to see. Richer countries have had some, I would say, biases with regards to reporting, which we can see they are often said to have more cancer diagnosis, but it is my belief that it's probably not more diagnosis. It's just that they diagnose a greater proportion of people with disease. The issue with many countries today, less so probably in Asia increasingly, but in Africa, is that rates are rising, but a lot of them remain undiagnosed, so are not reported here. Importantly, beyond that, we need to keep in mind that we are living in environments that are more complex and often harmful. I'm not saying of the wars in the Middle East or elsewhere, but I'm talking about, for example, air pollution. If we look at weighted PM2.5 concentrations around the world, which impacts not only respiratory conditions, but also cardiovascular health, metabolic health, and other aspects of life as well, including productivity. If we're looking at it from a societal standpoint, we can see that, especially lower middle income countries, parts of Asia, Africa are shouldering a great burden of disease or potential risk factors. On the other hand, we're looking at significant health workforce gaps, including in Indonesia, as you can see in the map here. We're looking at over 40 million more health professionals needed, even today, let alone in a few decades, with that increasing burden of the aging population. So this is something that's important as well. And one way to do this is certainly to integrate more technologies to empower those who are not doing things, for example, for health at the moment, so that they can provide their I would say, their skills to improve access or improve health delivery, be it through community health worker programs, through non-physician health workers, more of them being trained. But that is not the solution. I think one of the other ways we could think about it certainly is to see how can we make our environments and individuals healthier at the population level. And I think it's unfortunate to say, though, at least in Indonesia, I think I can say that you do have an agency for it. But in many countries, while this is happening, you can see in this diagram, a lot of them don't have public health agencies. So there is a role for governance as well. And that's something to keep in mind. The other trend to see is that health systems are exponentially growing. We're seeing exabytes, so it's not terabytes, right? It's exabytes of data generated annually from health systems around the world. It's growing at a rate of over 30% each year. Probably in time, it will be one of the biggest contributors to service space. And this comes from a variety of sources, be it diagnostic tests, increasingly ambient sensors, consumer data from wearables and others, some of the areas that I'm working in, sensors, IoT, wearables. And these are untapped data. And with tremendous potential if used appropriately to improve outcomes. This is something else to keep in mind. And then AI growth is certainly in the background. I think everyone likes to ask me, because of my role as well as co-leading our Digital Health and AI Hub, what I see AI as doing. I think in the short to midterm, we would see AI growth happening. But as with many people out there saying that it will replace jobs, I would say that it will replace those who don't adapt to use AI in their work. It's a disruptor, but at the same time, we've seen many past disruptions as well, including with the internet, right? That allowed us to do this meeting today being a disruptor. But people adapt, people change. I think those that don't adapt will be the ones left behind. And in healthcare, I think we often see a lot of laggards, unfortunately. But I hope times are changing. And at least for those in the call today, you'll be starting your careers in a world where AI is part of healthcare in big or small ways. And I think you have a role to play to help with that. And for the patients that we see, infodemics is the current challenge. It's circulating around everywhere, and this ranges from really disinformation, just really wrong information, right? But where we all have a role to play is on the left-hand side, to think about what are these questions and concerns and information voids that's not present. In this case, for example, for today's meeting, it could be on infectious disease like tuberculosis. It could be relates to metabolic diseases. The goal is to think about, in your own ways, being more health literate than many others, what are these questions, concerns, and information voids that's there, and how you can fill that. Because that helps healthcare, be it not healthcare delivery or being part of the health systems, because you'll be doing it through your social media, be it Instagram, TikTok, and others. So think about that, because these are voids that, if not filled by us who have a role and more experience or literacy in it, by misinformation and disinformation by other players who are doing it for themselves and harming others. We must also realize that commercial drivers are growing. I think the world, since COVID, has realized that actually healthcare is big business. I think many don't realize that, probably, interestingly so, beyond pharma. But healthcare itself is a big enterprise. For example, in Australia, but also in Indonesia, from my understanding, we're spending in Australia, for example, for a health system, over $1 billion each year to deliver healthcare. That is just in one system, rather than across all the hospital networks that we have here. In Indonesia, I believe about, if I get it correctly, over 300 trillion rupiahs are spent each year just by the National Health Insurance Scheme, BPJS. It's as big and potentially even bigger than the free school meal programs that is happening today. To put that into perspective, right? There is a lot of finances in it, a lot of players, and as a result, lots of commercial determinants. And this commercial determinants, if you look at it, comes from the political and economic systems, regulation, the public policies, and then going towards the environment and how they can help with health. And then moving downwards towards all of that, going to the meso level, be it in schools, be it in workplaces, with all of it impacting, in the end, individuals, making them have ill health and enhancing health inequities. So structural barriers remain in many parts of the world. I would say this is the case even in countries that are developed, like Australia, the US, for example. And these stem, certainly healthcare and quality is part of it, so the healthcare delivery. But if you look at this figure, the other parts that determines health are education access and quality, neighborhood and built environment, social and community context, and economic stability. Not everything we can intervene in by ourselves. And this is where, again, as the thinking of improving health by going beyond healthcare is very important. And some of this involves recently for myself looking at work to work with schools, for example, to improve health education and evaluate them in practice. This is just an example from a study I published a number of years ago, looking at a multi-country comparison of data, actually, what is being collected if we look at these countries across social determinants of health. Just standard stuff, we would think, that have been really shown to improve out or impact health outcomes, be it income, socioeconomic status. Education is not in this slide, but it's part of it. And we can see that even for those sort of variables, there is patchy in many places reporting. And that's an issue because we know that these are impacting outcomes. And I would say as a healthcare provider, as a clinician, we would need to know them to do our job even better. So I hope through this you've seen that achieving good health and well-being is not just shaped by health systems, and that good health is shaped by all of these and more. Good schools, public transit, active transportation, quality environment, affordable housing, fair justice system, universal design, and others. And that while we have a role to play, maybe in healthcare delivery, if that's where you're heading, it's important to keep that in mind. And that there's significant inequities with regards to health outcomes around the world in country. That's something we all need to think about and do more of. And keep in mind that health for one is health for all. And if I just go to this briefly, some takeaway. In many countries, for example, the curbs have been made wheelchair accessible by making it that way on the top left, making it able to for example, allow a wheelchair to be pushed by. And what's happened is it doesn't only benefit those with wheelchair, it benefits others as well. Likewise with closed caption, which was designed for those who are deaf, but helps a lot of people, for example, to learn English as well. AI does present significant potential, but if only we use it in a people-centered way and if used right. So my takeaways for today's keynote is these three. Achieving good health and well-being is shaped beyond the health system. Chronic diseases does require systemic approaches beyond treatments. Treatment is just one part of the puzzle. And commercial and social determinants of health are important levers to improve health for all. Thank you for your time, and please feel free to reach out if you have questions. And all the best for the rest of your day.
Thank you, Dr. Sunjaya. Your evidence-based perspective from the Australian health landscape offer invaluable comparative insights for us all. From Australia, we sail northward to the Philippines, a nation with a rich tradition of nursing excellence and community-driven health initiatives. Our third keynote speaker is an academic leader of remarkable versatility, a registered nurse, a Master of Arts in Nursing, and a Master of Business Administration. She serves as the Dean of the Faculty of Nursing at Far Eastern College, Silang, Cavite, Philippines. Let us formally welcome Ms. Riza Bautista Lumagui, RN, MAN, MBA.
Thank you so much. Good morning. Thank you so much for the kind introduction, sir. Assalamualaikum, everyone. Peace be upon you. So please allow me to share my slides, my presentation. Should I be the one, sir? I can't share it, sir. Hello.
Please wait, okay, Mrs.
Yeah. It's not enabled. I cannot share. Thank you.
For Ms. Riza, I'm sorry for the inconvenience. Please kindly wait.
Yeah, it's okay. So while waiting, so I'd like to grab this opportunity to thank Dr. Leo and Dr. Dean Rica for inviting us to be part of this hybrid seminar. It's really an honor we are humbled to be part of this hybrid seminar. Thank you so much.
Thank you for your kind support and participation in this seminar, Dean Riza.
Thank you so much, Dean Rica. I don't have the share button here. That's why I cannot share my slides. Please help. Thank you. No, it's not here. I cannot share. Wala. Supposed to be, it should be here. Yeah, kanina andito. Yeah, wait.
Okay, Mrs. Riza, we are still processing on the presentations.
Yeah,
Please.
we'll work on it too. Okay. I think it's working now on my end. Can you see it?
Yes, we can see it, Miss.
Okay. Thank you so much.
Thank you very much.
Just a while. Okay. So as a former infection prevention and control nurse in a tertiary level hospital here in the Philippines, I am humbled to share with you, with everyone, the Philippine Hospital Infection Prevention and Control best practices. Okay, so as an overview, working in a healthcare facility, actually, it increases the risk of employees' exposure to infectious agents, even those who do not have the direct patient contact. So it only means that our goal here is to keep the healthcare workers healthy. Actually, not only the healthcare workers, but also those because we also send here, we are already in academics or in academe. So I also send clinical instructors and nursing students to have their affiliation in the hospital. So everyone should be healthy in order to not to contract any infection once they will be exposed in hospitals. So at the end of this lecture, so I expect everyone to explain the organizational structure of the Infection Prevention and Control Unit. So later I'll be sharing with you there's the structure. And of course, you are expected to describe the core principles of the infection prevention control and how those programs will be implemented. Also to discuss the key components and implementation of the key programs of the infection prevention control programs here in the Philippines. So I'm very happy to share with you what we have here in the Philippines. Okay. So additionally, so you'll be identifying and explaining the links in the chain of infection. I know it's not new to everyone. And we're so happy because we are virtually surrounded by medical doctors. As mentioned a while ago, I'm a registered nurse. I'm a nurse by profession. But back in Riyadh and also in the Philippines where I work in a tertiary level hospital, we really collaborate with a lot of medical doctors. It's really a multidisciplinary approach. Added to that, you are expected to differentiate various types of isolation precautions. So we know what standard precaution is, what are those transmission-based precautions. And lastly, to describe, of course, the functions of the Infection Prevention Control Unit or office. So they also have the subcommittees. So later I'll be sharing it with you. So now, since I'll be sharing with you the best practices here in the Philippines, so this is our Bible here in our country. So we do have our national standards in infection control for healthcare facilities. So that is 2021 edition. It only means that all the hospital facilities here and other, whether it's a primary level, secondary, tertiary, or a specialty hospital, so they should comply with this, with the standards mandated by the Philippine Department of Health. So this Department of Health, we follow what is the standards of the World Health Organization. Okay, so what are those, what are these national standards? So there are 8 national standards in regard to infection control for healthcare facilities here in the Philippines. So we do have the management structure, functions, and responsibilities. Meaning to say, in a hospital, if you have put up or established an infection prevention control unit or office, it should be headed by a medical doctor. And then under that medical doctor, we do have several infection prevention control nurses. So we do follow the 1:100, meaning 100 one infection control nurse per 100 patients. So if it is a 250 bed capacity hospital here in the Philippines, so there shall be 2 to 3 infection prevention control nurses in that hospital. So aside from the infection prevention control, it has several subcommittees. Like, for example, it has a subcommittee for HIV/AIDS, for TB program, and also for the antimicrobial stewardship. But now it has been separated by the Department of Health, that one, the antimicrobial stewardship. Before, it's under the infection prevention control, but nowadays it has a separate office. Okay. So added to that, we also have the guidelines, policies, and procedures. It means there should be stringent guidelines to be followed by everyone. So everyone should be on the same page once you are implementing these infection prevention and control practices. Okay. So we also have the infection prevention and control education and training. This is one of the key components to really eliminate infection or prevent the spread of infection in any hospital or healthcare facilities here in the Philippines. So I know it's common to everyone. We have the healthcare-associated infection surveillance. So we don't want our patients admitted in a hospital to contract infection, right? After admission, after 48 to 72 hours, or else who's the culprit? Is it the patient or the hospital? That's why we really have to put those standards or those guidelines in place so that healthcare-associated infection, or previously known as nosocomial infection, will be prevented. Okay. Number 5 is we do have the multimodal strategies. There are a lot of strategies, multidisciplinary, that we are observing here. And also, we are also advocating the eradicate, for example, since we do have a lot of stringent guidelines, policies here in the Philippines, so definitely we have to monitor, audit, and have the feedback from the Infection Prevention Control Office. We have the surveillance committee, also subcommittee under the infection prevention and control. And we don't want our staff here to be burdened with a lot of things to be done, because we want them to be healthy, right? The one I mentioned a while ago. So definitely there should be an adequate staffing in every hospital so that they can really take care of those patients entrusted to them. Okay. Lastly, we have to provide them with a safe environment. And of course, not only the environment, but the enough materials, resources, so that they can really enforce and implement whatever programs that infection prevention and control is having. Okay. So I know it's basic to everyone. What is infection prevention and control? Simply, these are practices in order to prevent the spread of infection. Not only that, but it also protects the patients, visitors, healthcare workers, and those who are and other concerned stakeholders in that healthcare facility. So in regard to the principles of infection prevention control, so this is a basic and simplest way in order to prevent infection, which is hand hygiene, complemented by with cleaning, disinfection, and sterilization of equipment. And we do have here in the Philippines our national immunization program. So there are a lot of vaccines being given to the people here in the Philippines, or even in the patients seeking consult in the hospital. Okay. So added to that, aside from hand hygiene, cleaning, disinfection, and sterilization plus vaccination, we also have our monitoring and investigation. We don't want any outbreak to happen in a hospital because that is costly, especially for the stay of our patients. It will really prolong their stay. Now, there are proven, I'd like to share with you some proven effective infection prevention and control strategies. So as you can see in the picture, so we have the ventilation, what else? The hand hygiene, of course, the education, the AMS or the antimicrobial stewardship. We have the safe infection practices and a lot. So these are all in place here in the Philippines. So in promoting our IPC programs, so it's good. I heard from Dean Rica. So the Philippines is ranked as number 3, in regard to the number of TB cases worldwide. So she mentioned that there were 6.8% for accounted to the Philippines. So actually, if we're going to consider our statistics here in the Philippines, so there are 600 over 100,000 population per year who contracted TB. But the good thing here in our country, so we do have our law, we have our TB law in order to prevent or eliminate tuberculosis in the Philippines. Okay, so we do have our programs like the TB DOTS, tuberculosis direct observation treatment short course. We do have that one, and it's free. The sad thing is sometimes if they enrolled already to that course, sometimes they're not complying. So it should really be monitored multidisciplinary. It's not only the role of one person, but it should really be interdisciplinary. Okay, so now we proceed to these healthcare-associated infections. We don't want anyone to contract infection upon admission. So we know that its definition, once the patient will contract these HIEs, or sometimes it's called HCIs, or previously known as nosocomial infection, it means after their 48 to 72 hours of stay in a hospital, they contracted. So signs and symptoms of infections are manifesting or present to that patient, or even after, for example, a procedure has been done to that patient 30 days. So the signs and symptoms of infections actually are manifesting by the patient. So that's not actually, here in the Philippines, we can be complained actually by our patients if that will happen to them. There could be legal suits that can be given or submitted or given to that hospital. Okay, so in regard to these healthcare associated infections, so there are 4 key samples or examples of these HCIs. So we do have our ventilator-associated pneumonia. So it's common, especially to those patients who are mechanically who are assisted by mechanical ventilators. So we should really take care of our patients. We also have the catheter-associated UTI, or known as CAUTI. We also have our central line associated bloodstream infections, or what we call CLABSI, and the last one is the SSI, or the surgical site infection. We don't want this to happen. That's why these MDROs, all the multi-drug resistant organisms, some of them here in the Philippines, I sad to say, so we do have our isolates. Of course, we partner with the laboratory. Some of the isolates are the following, no? So we do have the Staphylococcus aureus, we have the E. coli, we do have our Enterobacter, we have the Klebsiella pneumoniae, and we also have the Pseudomonas aeruginosa. When I was working in that tertiary hospital, my God, we do have the outbreak in terms of this one, the Acinetobacter baumannii. So we really have to immediately isolate that patient with this one. Okay, so there should be really an active collaboration with the laboratory. So we do establish that. We're practicing that one here in the Philippines because we don't want really to investigate an outbreak. We want to prevent that one. Okay, so we want to translate this one into a positive practice or practices. So we really have to wash our hands. Of course, one glove should not be worn across all the patients that you'll be handling. So we have to change if we're going to take care of another patient. Of course, if we have to disinfect all the patient care surroundings, equipment, and of course the compliance with the antibiotic schedule. Okay. So now, I mentioned about the healthcare associated infections or the HIEs or HCIs. So it's good because there are bundles of care in order to prevent those HIEs or HCIs. So it's good because there are 3 to 5 actually short interventions. So in order to address the not the occurrence of that HCIs or HIEs, it's a yes or nothing, all or nothing approach. So I'd like to show you some of the checklists that we're using here in the Philippines. So usually it's being done interdisciplinary, no? If there's a meeting, so if there's peer reviews, so we have to sit down together with the doctor, admin, nurses, and other health allied professionals, concerned health allied professionals. So it should be incorporated in the patient's chart. So this will be reviewed by the doctor and a team, okay? So now we have to prevent this chain of infection. But of course, we have to understand this chain of infection. Of course, no one will get sick if we are critical in preventing the transmission of infection from the pathogen going to the reservoir. Of course, how it will exit that reservoir and how it will be transmitted to other person. And lastly, we don't want any susceptible host who will get sick, okay? So please remember that each and every one of us, actually, we're all responsible for breaking that chain of infection, okay? Here are some of the signages or learning materials that we post in our hospitals here in the Philippines so that visually they can be guided, they can be reminded apart from the education and training that we are providing to our healthcare personnel, okay? So the hand hygiene, we all know this one. If your hands are not visibly soiled, you do the alcohol, the hand rubbing. But if it is visibly soiled, do hand washing 60 seconds. So this is anchored in WHO, World Health Organizations, the 5 moments of hand hygiene. So before and after contact with the patient, we have to do hand washing. Aside from that, once we'll be doing an aseptic technique, we have to do hand washing. What else? If we came in contact with patient surroundings, so definitely we have to do hand hygiene, okay? So some of the materials that we use. And with that hand hygiene, respiratory protection, what else? The safe injection practices, it composes the standard precaution, wherein we consider all as potentially infectious. That's why we really observe these components, okay? We do not recap here. That's always a reminder here in the Philippines. Do not recap or even separate the needle from the plunger. So everything should be discarded to the puncture-proof container, okay? So it's an important reminder in case our healthcare workers suffered from needle stick injury, they really need to report it to the infection prevention control unit so that they will be advised to proceed to the emergency room so that they will be evaluated if the Hep B antigen surface antigen and even the antibody can be done. So it will be advised by also our medical doctor, okay? And complementing with the standard precaution, we have the transmission-based precautions. Okay, so, but it's good if it will be prevented at the beginning. Because here, once we're observing transmission-based precautions, complementing with the standard precautions, it means there's already a problem, a concern. So we have the airborne precaution, droplet, and even the contact precautions, okay? So I'd like to share with you some pictures taken during the pandemic. I was there in that picture. So we visited the intensive care unit of a tertiary level hospital in the Philippines. That's actually a COVID area in the medical intensive care unit. So we visited that because that's part of our surveillance audit. Okay, and we also do our inspection in the operating room because both the intensive care unit and the operating room are considered high-risk areas or at the red zone. And to conclude, I'd like to share with everyone that infection control, prevention, and control here in our country, our beloved Philippines, it's not just a clinical responsibility. It is a collective commitment to safeguard lives, so many lives, and uphold public trust. And of course, to strengthen the resilience of our healthcare system. And here are my references coming from the Philippine Department of Health, anchored in the World Health Organization. Thank you so much for your attention. God bless. Shukran Katir.
Thank you very much, Ms. Riza. Your emphasis on nursing empowerment and multidisciplinary collaboration resonates deeply, especially in the context of metabolic and infectious diseases management. Our final keynote speaker takes us across the Eurasian landmass to the United Kingdom. He is a senior lecturer in epidemiology, statistics, and research methods at the University of Derby. With an extensive background in global public health and wealth of experience of cross-country health policies, his insights are incredibly valuable for discussion today on infectious and metabolic diseases. Without further ado, please join me in giving a warm welcome to Mr. Dono Widiatmoko. The floor is yours, sirs.
Assalamualaikum warahmatullahi wabarakatuh. So thank you very much for inviting me for this event, Prof. Rika. Thank you, Mas Sandu. Apologies, this is still 4:17 in the morning, UK time, so apologies of my red eyes and so on. But thank you anyway to inviting for this meeting. So as you know, I'm also possibly a guest. I'm also an Indonesian, so I will mix my presentation in both languages and try to adapt it or link it with current Indonesian context and issues, if I may. But hopefully it won't be long. Let me share my material. Apologies, my oh, it's not linking. Sorry, technology. 4 a.m. in the morning. Sometimes not working. Anyway, let me just. Okay. How do I do it? How do I do it? Sorry. Where's my Zoom? Okay, share my screen.
No worries, sir. Take your time.
Okay. See, an error occurred. There you go. And let me just do it this way.
Yes, we can see it already, sir.
Thank you very much. So I would like to share the trends in global infectious disease with social focus in Indonesia. So I don't think I don't need to give context to most of the audience here. Because there are our international colleagues joining this. But basically, we are blessed to live. Well, you are blessed because at the moment I'm not based in Indonesia, with Indonesia, a land of islands, beautiful people, cultures, food, and so on. But also we have challenges in terms of our demographic challenges, our environmental challenges, our disease challenges, and so on. On the other hand, we also have opportunities. Let me just go through the top 10 infectious disease trends globally, and then try to link it with Indonesia. Where are we in this? So as Prof. Rika mentioned earlier in her keynote speech, tuberculosis is still there. It still is. It's still big. Indonesia, unfortunately, is placed at the second highest burden globally for tuberculosis cases in Indonesia. So years ago, I have started my research career in tuberculosis as well. Particularly because I have also personal experience, personal connection with the disease. My daughter was diagnosed with TB. That she was a small child at that time, and that sparked my interest in TB, especially the rising of antimicrobial drug resistance, which is a worry. Due to the difficulties of treating future MDR-TB cases. I think if you're most of the audience of this will be from the Faculty of Medicine, and we know the challenges of antimicrobial stewardship in Indonesia, how to manage antimicrobial antibiotics use in practice. I know a lot of, I live in the UK for more than 20 years, and it's difficult to find antibiotics if you are not within the healthcare, realm. So you can only get antibiotics, antimicrobials through for medicines, yeah, through your GP, to your doctors. But anecdotally, a lot of my friends, a lot of people that I knew that came to the United Kingdom for study, they're not doctors. They brought their own antibiotics. Whatever. I just want to go to Indonesia and buy antibiotics there. So that's anecdotal, but that's reality, isn't it? So yes, we have been hearing about BRT, antimicrobial stewardship. Prof. Rika mentioned about the importance of monitoring genes variation in CB and so on. But the key basic thing is still there. How do we ensure that the source of antibiotics that they have, especially here, tuberculosis, are used appropriately? Several years ago, well, I think it's still now, in certain communities, we heard people are using the Combipac, the TB 4 regimen medicines. For what? For preventing HIV in sex workers. So it's a bit hard, but that's the challenge. Anyway, let me go through so not to make it too long presentation. Second, it's dengue. Dengue, you know, is still a challenge. The new challenge, new intervention has been started in Indonesia, which is Wolbachia mosquito. It has been proven in trials in Yogyakarta. It has a huge efficacy and it's been expanded in several Indonesian provinces. However, there are infodemics, just like the previous speaker from Sydney mentioned, about everything, including these. There are stories about whatever, that this is a control, blah, 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 and so on. Obviously, from the academic point of view, we need to see the facts and evaluate its progress. Let's see whether this Wolbachia mosquito can control dengue cases in Indonesia in the future. If yes, excellent. But the basic things about dengue is still there. That is the control of factor, the control of the mosquitoes, which doctors can only treat symptoms, right? There's still no cure for dengue. The best thing is to prevent it. And prevention needs control of the dengue mosquitoes. What you call it? Saya lupa namanya. Juru jentik, juru jentik di Indonesia. It's still a key component, and I don't know. Check in your own communities whether these services are still there or not. The checking factor, living, breathing area. Third, HIV/AIDS, obviously it's still there. Life expectancy has been much more increased due to the development of ARV, antiretrovirus, but there are places where cases are still rising, and the 95 targets, that 95 of people are those who have HIV are detected, they are receiving ARV and so on. The achievement is only slow in Indonesia, but it is there. Another thing is, a good friend of mine, I mean, I thought as a public health worker, I can only see other people who gets HIV, but I was proven wrong. My very good friends died of HIV. So it still is a problem, a big problem. Avian influenza, still there. It's still kind of their background, but this is interlinked with poultry farming and so on. If you go and possible to zoonosis, possible link. If you go to what's it called, Pasar Burung, you can see. I mean, how cannot you be worried about this interaction between poultry, interaction between what's it called, animals, which can be the link of avian influenza with humans there. So there are One Health initiatives that have been going on in Indonesia, and Indonesia is an active member of it. Let's see how it goes. AMR, I've touched upon of the TB, but there are also antimicrobial in other area, E. coli, and so on. And this is a big ticking bomb. What's happened? Mpox, case reported in Indonesia. In the UK, cases have been up and down since 2022, but surveillance has been well established. High-risk groups of men with men who have sex with men. The gay population is high risk because of the context, health workers, and so on. So important to monitor this. Leprosy, old disease. We thought we have been successfully eliminating it. No, Indonesia is still there. Leprosy is still with us. Malaria, again, very old disease. It has been reported that this from the Egyptian times, malaria is there. Do we still have it? Yes, unfortunately. And we can see different challenges in the eastern western side of Indonesia. So we hope in integration of services of the Indonesian institution from Puskesmas, hospitals, Dinkes, and so on, can achieve better malaria elimination. Other respiratory diseases, we have many other new challenges about this viral respiratory diseases, not only COVID. We hope we can still monitor and control it, but the lesson learned from COVID is there. Right? We need to be persistent, resilient, but unfortunately, again, this the point that brought upon the previous speaker from Australia, that the COVID pandemic, sorry, infodemic, is worrying. It's worrying. You heard about the what's it called? I hope that I don't know whether you know it. I mean, you heard about it. That even the one of the governor candidate of Jakarta is a what's it called? A champion of COVID-19 hoax. Should I say? Anyway, last one is emerging factor-borne diseases, that lymphatic fibrosis, typhus, Zika, and so on are on the increase. So this is pretty much a linkage between environment, our lifestyle, and natural development of diseases. So again, One Health initiative is key important thing to implement in Indonesia. Now, at a glance, here are the cases that are in Indonesia. TB cases is there, dengue cases is there, malaria burden, leprosy, and so on. Yeah. You can see TB cases, for example, are up and down, but still there. Very, very significant cases. Drug-resistant cases annually is estimated to be 24,000 drug-resistant cases. When I did my research on the MDR-TB, obviously it's difficult to treat, very expensive to treat, and they mainly those who are fail to complete their medication to various things, and then they become drug resistant and so on, and a lot of the mortality from this groups of people, and they are what's it called? Generally from poor communities and so on. Anyway, let me conclude. The trends is here. They are still critical. Emerging as well as persistent cases, such like leprosy in Indonesia. It's still there. So it's our interest to monitor and control these trends. And in relation to what's happening in Indonesia, our previous speaker also mentioned about BPJS Kesehatan, about MBGs and so on. Yes, these infectious diseases are our challenges in terms of our health. But the structure, the things that make us possible to address these issues are these infrastructural, or is these structural issues. BPJS Kesehatan is on a challenge in terms of financial challenge, in terms of how to make it sustainable. If you're hearing about deficit, and so on. At the same time, MBG, that's also have been touched on, have, to be honest, more money than what? Than BPJS Kesehatan from the government. Well, as a public health professional, I actually should be happy with MBG, right? Because it provides an opportunity for future generations to be much more stronger, to be prepared in terms of their nutrition status. However, how it goes, who we target with, and so on are still different questions. So I think I will stop there. Thank you very much for listening to my presentation. Back to Mas Gede.
Thank you very much, Mr. Widiatmoko. Your concluding remarks beautifully tie together the threads of global collaboration and local action. A round of virtual applause for all four of our luminous keynote speakers. Dear participants, the main plenary Urgency 2026 has now drawn its curtains, but the stage is far from empty. We will now embark on the next intellectual leg, the parallel presentation sessions. For all student ePoso competition participants, please kindly enter your respective breakout rooms. Thank you for your attention, your enthusiasm, and your shared passion for global health. It has been a sincere honor to serve you as your master of ceremonies this morning. Good luck, enjoy the discussion, and see you at the award ceremony. Salam Bela Negara.
Terima kasih.
Good day. Maybe we can have a picture
Yes,
photos
Prof.
together.
All
You
right,
can
Prof.
highlight all the speakers.
All right, Prof.
Like for speakers together in one screen.
I kindly invite the signing parties to join in a virtual photograph, a moment we will capture together as a memory of unity and shared purpose. Okay, on the count on 1, 2, 3, we will start the presentation. 1, 2, 3. Again, once more. 1, 2, 3. Okay. Thank you very much.
Thank you. Dear Risa, Dr. Anthony, Pak Dono, sehat selalu. Keep healthy and happy forever. Bye.
Thanks, everyone. All the best.
Thank you.
Aku makanya tesisnya tuh kayak kita jelasin itu ulang tahun. Emang kayaknya baru kita bilang semua itu tuh menjurus ke satu diagnosis. Jadi sering-seringnya aku udah selesai terus aku juga gitu. Soalnya kalau FBS kan kita sampai selesai. Iya. Kalau yang sekarang tuh lebih kelemahan dengan ELCO sih. Ada aku yang udah FBS itu harusnya nggak ada beban, nggak ada kerjaan.